So today we are going to discuss about, first we'll review the post-transplant outcome of our patients. So like only like few disease like I have put, which we are facing during the patients when they will relapse or refractory some things, and we'll review some mixed chimerism, how many mixed chimerism were there and how much they are doing well. So and along together with that, like how DLI is working, so how, like what is the complication, what is the risks about it, and we'll briefly will discuss about chimeric antigen receptor cell therapy outcomes and complications. So first we'll discuss about review first post transplant outcome. So next slide, sir. So this is the slide. Actually, I have taken only the severe thalassemia survival chart of our center, like Bangalore center only I have taken. So total we have transplant 179 patients. We have done the BMTU. In overall survival rate is 91.4 percentage, like in almost 7 years of journey. Like in 7 years of journey, like we have transplant these patients. So in that, like survival rate I have done. So disease-free survival rate is 87.3 percentage. Transplant related mortality is like 6.9 percentage, rejection 7.7, GVSD also were there, so 19.7.
We cannot hear you, Bina. I think we have a problem with the connection.
No audio from Bina.
No, Bina
Sir.
is disconnected, so she has a problem.
Sorry, sir. Actually, I have a problem with my network, sir.
Yes, Bina. So do you think you want to try to continue, or should we?
Yeah, I'll continue, sir. Actually, due to rainy, so yeah. So this one is the I have put the survival chart for the severe plastic anemia. So total we have transplant up to this time. So 10 patients were there. So in that, actually the survival rate and the total like transplant related mortality is like come to equals one. So GVS plus disease free survival is 58.4 percentage, and the TRM is 41.6. So yeah. So next slide, sir. So despite the vast improvement in survival, a subset of patient will experience relapse. So many things will be there. We expect the most patients engraftment after the day plus 12, after the transplant for bone marrow infusion, And for lots of patients, so other patients, they will have like other malignancy patients, they will achieve a remissions after the first month of chemo, or late with 2 years also, and their treatment will continue for 1 year approx. So these actually, like I'm talking about both like this aplastic like malignancies also, and all those. And approximately so 15 to 20% of patients eventually relapse. So in that, like some of there will be difficulty in compiling with the prolonged and maintenance therapy will be there, because they can't continue all this, they can't maintain the therapies, and high risks of feature will be there, and aggressive cytogenetic abnormality will be there. Next, sir. So therefore, these patients with early relapse, considerations with the hemopoietic stem cells transplant after attending remissions with reinduction chemotherapy vastly improve outcomes. So patients who were actually treated with chemotherapies along like suffer further relapse or death from toxicity from the chemotherapy or from disease progression. As a standard of care therapy for patients with early relapse is to proceed to allogenic transplantation. So these are like I have just put the high risks and relapse of hemopoietic cells transplantations. So next slide, sir. So here I have put the mixed chimerism. This will talk about our center only. Only for this disease we are treating for the aplastic Fanconi, severe thalassemia, and sickle cell. So in that, like almost 79 patients were mixed chimerism. In that, overall survival is 94.9 percentage were there, and GBS and disease-free survival is 84.6. Rejection, like of course mixed chimerism is like so they can get rejection after some time, like secondary one, but not like not the primary things. So rejection percentage is 15.5 percentage. GVSD also they can get it 8.6, and some of them like TRM, that transplant related mortality, so minimal rate will be there 1.7 percentage. So if they're on if uh, the cells were not working, so maybe that can be like fatal rates will be there. So till here, like to summarize so far is like for patient with severe thalassemia and aplastic, most patients are able to achieve sustained survival with the transplant. And other, if we'll talk about other patients, so approximately 15 to 20 of the patients relapse, and some of their patients required the stem cells transplantations to try to prevent further relapse. But the transplant is most helpful for patients who are able to achieve survival for their kinds of patients, especially when the residual disease can be identified. So like if they can identify the disease like ALL, AML, CML will be there for them, like it will be very like good for them. We can see that challenges remain for the patients who are unable to achieve remission, either those who are refractory to unfriend therapy, or those who are unable to achieve remissions after the relapse, like ALL, CML, or CLL. Up to this, like these peoples, they can't we can go for like other treatments. So here short topic, not that much big, so everybody knows like in our centers we are doing DLI. Like this is also like one kind of cellular therapy for the post transplant we are doing. So here what is DLI? So first thing, so donor leukocyte infusion. So why we are doing so? Only like to save the graft, right, for our patients. And like we can consider as the salvage therapy at the time of relapse. Like if it's the patient condition is worsening, the graft is not working, so that time we can save the child life after giving the DLI. So this can also be purposed for varieties of hematological malignancies that include CML, AML, this MDS, hot skin disease. For this also, like this transplant, like for them also we are using this one. And like, yeah, of course, this DLI is established therapy of hematological malignancies relapse after the halogenic stem cells transplantation. So the most complications of DLI is only the risks of GVSD infections. So that's what, like whenever we are planning to give DLI, so we need to check all those things. Like we'll check the chimerism if it's going down aggressively, so we'll give DLI, and we'll give a small volume because we don't want patient to get GVSD. If that is also another kind of infection we are giving to patients. So that's what, like we'll be very careful about that while giving the DLI also, because we need to see lots of criteria about that. So that thing. So the next slide. So here we have, see, you just complete everything. I have put animated, so that's it. So okay, so most recently, like different approaches of treatment for these patients, like different cellular therapy will be there. Like mostly we are using like different before immunotherapy, or trying to harness the ability of the immune system that to read the body of foreign or abnormal cells. This was the first done using the SPCT, so that we are doing, where a new donor immune system can survive and the eliminate any remaining leukemia or like any other diseases, like how we are doing in our center, like thalassemia, like will reduce, like will eliminate the disease, that one. So but as we already discussed, this form of immunotherapy is limited when the patient have a significant remaining disease burden, right? So other approaches have attempt to create monoclonal antibodies to eliminate uh, cells that express certain protein, like the use of rituximab for treatment of CD20, and for the malignancies. So this one, like everybody knows the rituximab we are using. So when we are using the rituximab for our patients, when the patients are haplo, and if the patients chimerism are dropping, so like so many criterias are there. So for that, but we can use as cellular therapy also, this one. And another is by specific T cells engager. So this one is also we can call as by therapy, bind both T cells and a cells with a target antigen, bringing them together. So you can see the image together, and the eliciting a cytotoxic response, the most well known as the B cell, like we mostly use for the B cells ALL, like for them we are using. So you can see the medicines names also I have put there, belinatuzumab and the inotuzumab, this like we are using for that. And then now, like we have new tools in our like setting. Even I heard the first time this CAR T therapy, so chimeric antigen receptor T therapies. So this is good opportunity to explain you guys. Even I am having lots of doubt during this time, so we'll discuss a little bit brief about this so that I can explain you also. So next slide, sir. Am I fast, or it's like everybody are understanding?
Bina, it's okay.
Oh, okay,
Good.
okay, thank you. So here I have put what is CAR T. So first, C means chimeric, A antigen, and R receptor, and T cells. So T cells elicit a cytotoxic response to foreign antigen. Leukemia persistence because it inhibit like embed detection by the immune system. CAR T harnesses the immune system to fight the cancers, and the autologous T cells are manipulating to target leukemia, mostly actually for that. And the primary target is, most primary target is CD19, a marker on pre-B ALL cells. So here, like I have put the researcher that have brought a CAR T as a breakthrough treatment begins over the 30 years ago. So in late 90s, 80s, and the early 1990s, researchers were first able to alter a T cells in vitro to kill a target cells, and this leads to first generation. You can see the image, right? So there, this leads to first generation CAR T cells in the 90s 90 that were able bind the target but not sustain cells killing. In the early 2000s, first generation CAR Ts underwent additional changes that vastly improved cells killing in vitro, and cells were able to persistent in mouse studies. So they did the mouse studies. Then in the late 2000s begins the first human research uses CAR T, and in 2000 the first studies began showing the promises of CAR T therapy in adult with the B cells malignancy. So that we did, and then 2013 researcher at the children's hospital, actually they have been first treated two children with the refractory leukemias who had failed all the available treatments options with the CAR T cells, and these children were able to achieve clinical remissions. This prompt and the explosive in the CAR T researcher and the clinical trials. In 2017, the FDA approves two CAR T products for the treatment of B cells malignancies. So then after, yeah. So here, like the chain I have put here. So benefits in CAR T therapies is the uses of patients on T cells to generate the CAR T cells. So a patient undergoes leukapheresis. You can see the image. The patients will undergoes leukapheresis to collect the patient's T cells. A manufactured T cells receptor that target CD19 or other tumor specific antigen, and then transfer into the patient's own T cells through the help of virus. Then T cells then grow and begin to express this new chimeric T cells receptor. When the cells are infused back into the patients, the T cells then find the cells that express their CD19 target and eliminate them. So you can see the full all this process over here. So this is the process how we are doing. So put three pictures were there. Yeah. So in so go back. I think I missed that one. Yeah. So this one actually I have put the like images so that little bit it will be understanding for the evaluation of chimeric T cells receptor. So this is ability to generate a T cells receptor to target the specific antigen on the leukemias. Actually, mostly they will use in the leukemias patients. When the research first begins, the T cells receptor only had the three parts. That first one is the receptor to bind a certain targets, and the second one is the transmembrane domain to pass the binding signal to an activate portion within the cells, CD3 zeta. So, but leukemia killing did not reliable occur because additional signal, the T cells did not proliferate and the underwent sensors or the like fatal, it happens self fatal. So a second, you can see second generation of receptor was designed. That second generation chimeric antigen receptor have been shown to be effective and are the one begin used in much research as well as in the available commercial product. But the researcher is going ongoing creating third generation receptor that have two co-stimulating domain that is further improving activity and the persistent of the T cells. So these are like three things they were using to like improve the activities and persistent of the T cells. So here, are all CAR Ts created equally? No, actually, like there are various things. So CAR T therapy have largely grown out of the work of few institutions, each with the slightly different approaches to their CAR T construct. The CAR T cells product can range in their tumor specific target. Actually, they will target the specific tumors. The most studies are CAR T that target mostly CD19. Although there are ongoing studies of other targets, the CAR-T design can differ in their cost stimulatory domain, some using 4-1BB domain and other using CD28. So, but of which act as the second signal to help improve T cells activation and the persistence. And last one is the virus used to transduce the receptor into the T cells can differ, but so far outcome using the different CAR T product have all been shown to be effective in inducing remissions. So these are the three like different one using like how they are created. So here like CAR T cells induce target leukemia. So any animation is there. So next if you do how it works. So first one, CAR T cells that express the CD19 receptor. So it will be like it will bind the CD19. So next it you press, so it will bind the CD19. Yeah, so it binds the CD19, express the leukemic blast. So if you press another, it will blast. So for image, yeah. So it cause like the T cells is activated and the produce a cytolytic response, the killing of and that it kills the leukemia cells, right? So because the T cell persistent, it can continue to move the cells to cells, eliminate all the cells that express CD19 and hopefully leading the clinical remissions for the patients. So this how it act in the leukemia patients, like the leukemia cells dead. So next one. So this is actually the first CAR T therapy we use for the first patients. Like she have been like done before 5 years. So she is doing well. Like it was done in Children's Hospital of Philadelphia, Phila- Philadelphia. So this one. So there it was done. So this only I have just put this image actually to show images. So next one is the CAR T therapy leads to high rate of CR. So that means so if the number of 30 children and adult with the pre-BALL, so 80% of had detachable leukemia prior to infusion and 90% achieved complete remissions, and only 7 of these patients later relapsed. So total number of events free survival is 60% and overall survival is 78%. So for this CAR T therapies, which will lead to this one. Another one is results were valid in international studies. So if they have taken 75% received the CAR T infusion, in that 81% patient achieve remissions and 59% relapse. At the month of 12 month, it relapse actually, and 22 patients relapse. 68 were CD19 negatives at the time of relapse. So unique complication of CAR T. So this is like you can see. So complication of CAR T, how it will be there. So what and all. So low IgG levels. That CD19 is normal marker on the B cells and can be marker of CAR T persistence. So we can treat with the IVIG. We can give them, and cytokinase release syndromes will be there, and neurotoxicity also will be complications of CAR T. So the most complication is these two, cytokinase release syndromes and the neurotoxicity. These two, I put the examples so we can go through it. So next one, sir. So here, like I have put some examples so that we can understand how it's happened. So cytokinase release syndromes. So 12-year female received CAR T infusion. After she fails to respond to infusion, cytokinase release syndrome occurs.
We cannot hear you, Bina.
Unstable.
No.
Yes, sir.
Okay. No, we lost you for a minute.
Yes, sir.
So that PPT is not getting shared.
I can see.
Because we can see this as some mail has opened, such mail.
Okay. Now its mail is open. Yeah. So we'll go, sir. We'll continue.
Yeah, please.
Okay. So like where I was there. So she started on antibiotic. Her blood pressure become unstable. So 70/30s. So we have given IV fluids. So escalating with the vasopressors. So she requires oxygen too. So this is due to concern of cytokinase release syndrome. So we have given the dose of tocilizumab, and like after that, like she was clinically improved. So these like the examples. So next, sir. So CRS actually, it's a potentially life-threatening systematic inflammations. So due to cytokinase release, so predominantly mediated by IL-6. That means this interleukin-6. Okay, full form of that. So this is endogenous chemical that will activate the inflammations and during the B cells maturation actually. So approximately more than 75% of patients experience CRS. So severe and life-threatening CRS occurs in 27 to 44%. So increased CRS means when it will be there. So higher CAR T cells doses, if we give, higher disease burden or concurrent infection will be there. So to treat that, we can give supportive care, anti-IL-6 therapy, the tocilizumab, cetuximab, that we can give. Try to avoid steroids if possible, as may impair CAR T cells. If we give steroids, like that will harm for the like impair the CAR T cells. So for that we are like we'll avoid that one. So next. So here is the CRS grading ASBMT guidelines. So there is 4 grades. So grade 1, grade 2, and grade 3. And in grade 1, there will be high fevers more than 38 degrees Celsius, but there will be no signs and symptoms of hypotension and hypoxia. But in grade 2, there will be high fevers that more than 38 degrees Celsius, but hypotensions will be there, but not requiring vasopressors, and or it requires the hypoxia, like we require the nasal cannula, like a little bit supplement of O2. And in grade 3, there will be high fevers requiring one vasopressor, or like requiring a high flow of O2. And grade 4, there will be high fever like and requiring multiple vasopressor and requiring positive, like the patient needs a ventilator that time. So this is the guideline of CRS grading, how we can grade them. So next, sir. So immune effector cell associated neurotoxicity. Here also, like I put example, so for that we can understand like briefly. So 13-year-old male received CAR-T infusion 10 days ago for refractory B cells ALL. So he had CRS requiring a brief ICU stay, but improved and was like prepared for discharge home. But that time he began of complaining headache and version and unable to answer questions or talk. Like he is less awake and less alert, and like he was monitored closely, had no seizure evidence of cerebral edema, and like gradually improve over the next week with the supportive care and rehab. Other than we are not doing for this supportive care and rehab, only we are doing for this. So here neurotoxicity can cause cerebral edema and the like fatal death it can cause. So there will be 25 to 50% of patients that can occur. So sometimes headache can be non-specific, and aplasia will be there. The patients can't talk or able to talk. So can progress motor weakness or consciousness like seizure, cerebral edema or fatal, it will be there. And the pathophysiology of neurotoxicity is not well understood actually in this case. So then we can treat this neurotoxicity by giving the supportive care only. So neurotoxicity grading as per ASBMT guidelines. So for grading scales available for the adult and children more than 12 years old. So first, level of consciousness will check motor findings, seizures is there or not, increase intracranial pressure. And for the below 12 years, use corneal assessment of pediatric delirium, that is eye contact, communication and activity response, like how to check this neurotoxicity grading. So this one. So relapse can also occur after the CAR-T infusion, like mostly after giving the treatment, we'll see, okay, there will be no relapse. But of course, like after giving the CAR-T therapy also, there will be a relapse that can also occur. So there will be a two kind of relapse, that is CD19 positive and CD19 negative. So CD19 positive is poor persistent of CAR-T, and CD19 negative means like from new mutation in the leukemia that is no longer recognized by CAR-T. So this can be there. So and the last, but I wanted to highlight that the field of actually the cellular therapy and the immune therapy is constantly growing to include more than just autologous chimeric T cells receptor. So there are lots of studies to evaluate allogenic CAR-Ts and CAR-Ts for the solid tumors. These are there, and even there are the studies of evaluating the T cells that target multiple tumor specific antigens, similar to approach used to target viral infections. And like there will be lots of studies of to generate chimeric receptor in other cells, such as we can call natural killer cells, and so many were there. But this is the like rapidly involving in everything, so it's like we are dealing with all those things. Actually in our center we have not started these things, but yeah, it's a good thing to learn about it to improve the survival for our patients. So yeah, this and this one. Thank you everyone. So any doubts?
Thank you, Bina. I think, yeah, this was a very complicated presentation, Bina. I think you did a great job. Yeah, the issue is that as part of the APP core competencies, we have also to discuss this new cell therapies, which of course are a bit complicated. You have never been exposed to it. But the whole point of giving you the opportunity to go for a month in a high-tech JC FACT accredited center is also to try to create an opportunity for you to be exposed to these therapies so that you can have a broader sort of understanding also of cell therapies. I will very briefly summarize before we move to the next talk, and please, feel free to ask any questions. But CAR T cells essentially, just to summarize what Bina has said, are genetically engineered T cells in which the probably most active system that it causes activation and proliferation of T cells, which is the IL-2 receptor, instead of is genetically engineered so that instead of it binds directly and is activated directly by the CD19 receptor, so that any CD19 carrying cells, whether it's malignant or normal like B cells, will cause a very, very massive T cell activation, because in this genetically engineered T cells, it will directly activate the most potent activator of T cells. And that's why you get a very important clinical response, but at the same time, the consequences of massive T cell proliferation, which is the cytokine release syndrome. Also, as Bina has mentioned, these CAR T cells do not differentiate between malignant and non-malignant CD19 carrying cells. So CD19, so all B cells will be eliminated. And that's why these patients may have persistent problems with production of immunoglobulins and may need immunoglobulin supplementation long term. And so this is one of the main issues with CAR T cells. Of course, again, as Bina has mentioned, not